believe we're missing Prof.
Yes.
Agwanda.
Professor Agwanda, and he's the first presenter. Rose, can we look for him?
Yes.
Oh my God. Rose, I cannot hear you. Are you talking? Rose, is it mine? Can you type? Professor Agwanda, is he on board?
Trying to reach is currently busy. Please hold or call back later. Safaricom is for you.
May we start with the next talk and then come back to his presentation?
I think that will be better. I can start and then as what? Okay, thank you. Somebody is taking over the screen. All right, I do agree with you, Professor Nduati. Panelists and viewers and audiences, welcome to this session. We are tasked today to discuss in this population conference on issues of adolescent fertility and how it affects or impacts population management in this country. And therefore, I will ask the center to share my slides on what the government view is on this. Is anybody managing this platform for us? Or I can just share my screen from my, I was informed that there will be a central point where they will share the screen. If not, then I can share my screen from my computer. Can somebody guide any IT person? Francis Kundu, I can see you are here. Anybody from NCPD who can help with this?
Yes, I was supposed to assist you on that one. I'm James.
Yes, James.
But I think if you can learn it yourself, it will still be okay with me.
All right, thank you.
Thank you too.
Can you see my slides now?
Yes, we can.
Thank you. Family health. In family health, we have different programs, divisions. We have Division of Reproductive and Maternal Health, where family planning and population issues fall. We have the Division of Child Health and Neonatal Health. We have the Division of Adolescent and School Health, and the Division of Nutrition. I was the former PA coordinator issues of RMNCH, at least in the 15 high burden counties of maternal mortality. Before that, I was the chief of party for Asia program, which is also a family planning program. Prior to that, before 2013, I was the head of the division of reproductive and maternal health. I am an obstetrician and gynecologist by background from University of Nairobi. My undergraduate is from Hacettepe University in Turkey, and I have a fellowship in reproductive and maternal health from Tulane University in the US. I'm happy to moderate on this panel discussion on adolescent fertility and human capital development. We have with us many expert panelists on the same. I will introduce them and read their bios as they present their contribution. But with us is Professor Agwanda from PSRI, University of Nairobi. We have Professor Nduati from University of Nairobi also, School of Child Pediatrics and Child Health. We have Dr. Ann Kihara also from University of Nairobi, and also the former president of COPS and the current president of AFOG, African Obstetrics and Gynecological Society. We also have Pamela Onduso from Path, who is also from Civil Society. And we have one or two adolescents who are representing the population at hand that we're discussing. And we will, as we go by, details. Without much ado, we have already taken time, technology, as the moderator and setting the pace for the discussions to follow. Thank you. Therefore, we have the background, adolescent health and fertility in Kenya, reflection on adolescent fertility and human capital development. That's the outline of my presentation. Who are adolescents? We need to define that. People have different, what do you call, definitions and different understandings who are adolescent is. As per WHO, any person age of 10 and 19 years is the one who fits the definition of adolescence. There are 11 million adolescents in Kenya. That's quite a sizable population, and that's about a quarter of our population. And 70% of them are in rural areas. Legally, we have subsets that are minors, 10 to 17 years, and we also have legal adults, which are 18 to 19 years. So we have lumped populations that are legally recognized as adults and some that are legally recognized as minors into one cohort. Socioeconomically, most of them are dependents. Primary level 10 to 14, secondary level are 14 to 18, and some are in college at 18 to 19 years of age. So even their socioeconomic diversity is quite clear. Human capital development perspective. Childhood includes adolescence. Including adolescent is most adaptable period for cognitive development. And that is, the cognitive development is what steers national development in totality, driven by health, education, and stimulation. So for us to have a tangible quality population that can steer development in the future, we need to have populations that are taken care of from childhood through their adolescence so that they become useful population and not a burdensome population. From health perspective, these are driven by their evolving physical growth, sexual maturation, emotional development, and cognitive development. So all these developments that are happening within these adolescents happen at different strategic times, which require strategic input for them to have a smooth corridor of safety to achieve the potential they want to achieve in life. The fertility in the context of adolescence. Childbearing is celebrated for continuation of generations and posterity, and that has been alluded to in the opening ceremony, session, that it is a human need for generational continuity to prevent extinction of human race. So continuation of generations and posterity is a celebrated thing in life and in social development. When done at the right time, it is reflected in the social, economic, and health indices. For the lower age band, fertility is largely driven by numbers in the age band entering sexual activity, while the older is by family size planning. So the sexual debut is an indicator of how fertile our adolescents are. Delaying age or aging of childbearing has an important impact on fertility levels and trends overall, and increases period of optimized human capital development. When childbearing starts before the age of 20, the period available for childbearing lasts for approximately 24 years, and this is the period of high fecundity, ending until around the age of 35. It's 17 to 18 years long. However, early childbearing creates a challenge in effective human capital development. Adolescent fertility is the probability of an adolescent having a child, and having a child is preceded by sexual debut. The number of births, adolescent fertility rate is the number of births to a woman aged between 15 to 19 per 1,000 women in that age group per year. That's the WHO definition. The adolescent birth rate is affected by changes in the number or percent of adolescents exposed to the risk of pregnancy, which is sexual activity. For example, when age at marriage is rising or reducing, quickly for the benefit for the 15 to 19 years of age, increase in age of sexual debut within the age group. Changes in the age and the rate does not necessarily mean the impact of family planning programs on fertility. Adolescent childbearing declined in the late 1980s and 1990s due to decline in population of women marrying during their teenage years.
James, what has happened? Are we okay? Am I still in this session?
Yes, Ruth, you are still in this section. I'm trying
I think we've lost the presenter.
So
Yes.
can I help with the presentation as we try to trace? I don't know who can try get Dr. Bashir, but I can support him with the presentation.
All right.
So I can't see it on the screen.
Okay, Ruth, let me check with our ICT team because they are the ones now that they are sharing the screen currently. Let me get to them.
Can the presentation be
Yes, let me get to our to
okay.
James.
Maybe
Yes.
it's an IT thing. Okay. It's okay. Could you please project the presentation as we wait for him?
I've joined back, I've come back, but
Okay.
that's taken long to come back.
Okay, sorry.
So let me see whether I'm not able to share my screen. Can you allow me to share my screen?
James, if you're in the room, kindly let Dr. Bashir
share my screen
share.
or share my screen.
Yes.
I have removed mine. Let him share.
Okay. Okay, James.
Thank you.
Okay, thank you. Sorry. This technological hub. I don't know what happened with the internet connectivity. We were looking at this slide. This slide depicts that there are a lot of issues that go in the of the adolescent, and all this thing needs to be processed properly and with the support of the social, what do you call, the community, from parents to the educationers, schools, and the society at large. So this slide shows us about the sexual debut, and this is 2014 KDHS, and age of first intercourse. For the female population of age between 15 to 19 years, at 15 years of age, 10.7% of them have had sexual debut. And at 20 to 24 years of age of female, they had their first intercourse at 15 years of age. 13.6% of them had their intercourse at 15 years. So if you look at this, for the male, it looks that there are higher population that go into early sexual debut than the female. When between 15 to 19 of female at 10.7% started their age, sexual debut at 15, for the male it is 19. And a proportionate increase also for the age set of 20 to 24 years of age. By 20 years, 71% are sexually active for the female and 78% for the male. Trends in age-specific and total fertility rates. This slide literally shows us that we have been having a decrease in the total fertility rates for these age sets. In 1978, we had 168 per 1,000, but right now in 2014, we had 96. The last decade, the decrease is slow. Maybe we are coming to a plateau, but it shows us that the age of sexual debut is increasing. The other health indicators for this population that is important that we need to bring in are that 51% of the new HIV infections and 13% of AIDS-related deaths occur among this age set of 15 to 24. You see now we've gone to 24 from 19. So there are a lot of, this cohort has different bands from 15 to 24 years of age are put in the same band, but they have different needs and demands. 18% teenage pregnancy as per our last statistics, and maternal mortality ratio or rate is twice as high in women between 15 to 19 years of age compared to those who are 20 to 34 years of age. And this is our KDHS 2014. A third of maternal deaths in this group was second or third pregnancy. Therefore, they are quite young. 6.5% of girls and 2.7% of boys aged 15 to 19 years have ever experienced sexual violence. This is another need, and that's COVID had brought this, both this teenage pregnancy and violence against young people have been brought forth by the pandemic of COVID, and maybe a lot of mental health issues. Fgm prevalence among girls aged 15 to 19 years is 11%. And this is the age set where this activity actually happens. 6% of females were married by the age of 15 and 26 by the age of 18, according to the KDHS 2009, and we did not have this question in the KDHS 2014. 18% of adolescents aged 15 to 17 years reported ever using any drug. This is another perspective, drug abuse and adolescent health. Specifically, 2% of females and 4% of males between 10 to 14 years, and about 11% of 15 to 17 years reported ever using alcohol. This is according to NACADA 2012 statistics. Reflection, adolescent fertility, and human capital development. What is it that we need to reflect on? Are we drowning? Are we allowing our population to drown? Or we have strategies to save for posterity? Reflection number one. What are the drivers and other undercurrents of adolescent fertility? One is poverty. Two is sexual violence and retrogressive cultural practices like FGM. Three, what we call the toxic triangle of influence of peer pressure, new media against adolescent and youth, people's lack of requisite knowledge, skills, values, and attitudes to make concrete decisions, and suboptimal parenting. So the triangle is the peer pressure, the lack of skills of the adolescents to survive this journey, and suboptimal parenting. These are the three poles of the triangle, which is called the toxic triangle. Drug and substance abuse is another issue that drives this, and suboptimal segmentation and responsiveness interventions for a heterogeneous population of 10 to 24 years of age. The undercurrents, the same social and economic circumstances that predispose adolescents to engage in unprotected premarital sex and pregnancy are also critical factors in early school dropout. Here we're talking about once a teenager becomes pregnant, the probability of dropping out of school and therefore curtailing their potential growth in national development is unquestionable. And there are two people, not only one, but there are two. The cycle and the vicious cycle of poverty not only affects the current adolescent, but also their offsprings and generations to come. What happens to a child being brought forth to this world by an adolescent who is not skilled, who is not empowered, and who is forced to take care of a child coming to this? What we have seen in Cliffy is a cycle of vicious cycle of poverty, generational poverty. Like the great grandmother is around, poor, the grandmother is here, the mother is here, the child is here, the grandchild is here, all in the same lifestyle and without really much hope in the future. So we are not talking about the adolescents of today, but we are talking about generations which are going to be in line, will be brought forth into this world through this adolescent fertility. Therefore, adolescent fertility has a negative impact on health, school continuity, and functional relationship between the adolescents and family and community. Its effect on human capital development is the girl's human capital development interruption and the baby's suboptimal chance at human capital development. What are the policy environments that we have in the country today? Adolescent pregnancy and fertility is a great impediment for children, girls, and women health, economic empowerment, national prosperity, and gender equality. We have robust legal and policy instruments that prohibit and seek to eliminate child labor, child marriage, FGM, gender violence, improvement in health indicators, particularly pandemics such as HIV, free access to maternal care and adolescent-friendly services, non-performance-based 100% transition in education system remain critical in ensuring adolescents' school continuity. What are the opportunities we have as a nation? A change of mindset in the sense that adolescent childbearing and its impact reflect a host of many undercurrents. Let's address them and have a different perspective. Once an adolescent is pregnant, it doesn't mean that they have been tied to the shackles of poverty forever. There are other opportunities we can provide, and there are strategies in place. If adolescent pregnancy happens, it need not become a permanent endpoint to a girl's human capital development. Genuine human capital development concern in the context of adolescent facility must reflect on both the mother and the child to break the cycle, as alluded to earlier. We reconsider a response approach and scope, make the adolescent corridor safer, adolescents much more resilient, and have a dignified recovery plan and healthcare for the teenage mother and child with a clear linkage to human capital development ventures for both. We run with the quick wins already in place, optimal implementation of the government policies, including menstrual hygiene policy, school re-entry policy, 100% transition rate, free primary and secondary education, and integration of pregnant learners back to society and school. Accountability where it matters. Parental presence and family support must be enforced to foster adolescent resilience and recovery. Parents must be accountable for their role and don't leave these issues to teachers or the system of education and also other government departments. Parents have a role, government has a role, education line has a role, and everybody must play their role. And we must be accountable towards this adolescent cohort. We address the obvious gaps that we see: systematic financial and childcare assistance targeting teenage mothers, their children, and families. What we have seen in a field visit in Kilifi was the main issue that forces these adolescent girls to go into sexual activity. Sometimes we make a mistake, but it is really a need for menstrual hygiene pads, for transport to school, for school fees, and such things. Once they drop out of school because of childbearing, they have to sustain those children. And therefore, there's no hope for them to come back to school. If there's support of these poor teenage girls, for them to continue their education, first of all, to prevent the pregnancy itself. And if the pregnancy happens, for them to be supported with that child to continue their education, then we'll see light at the end of the tunnel. But if we don't cut that cycle or break that cycle, we are unlikely to achieve the demographic dividends for this country. Investing in relevant, timely, strategic information and communication and advocacy, together with the society, with the leaders, and empowerment of and partnership with adolescents and communities. Where is their voice? Where are they? Are they contributing to this, to address poverty of hope? That is my opening remarks for this session. And I can now stop sharing my screen. I hope we can cover the time we lost on this, and we will allow flexibility for our panelists to do their due diligence on their presentations. And therefore, if Professor Agwanda is on board, may I take this opportunity to welcome him? Is he there? Please.
Yeah, I'm there. I'm
yes,
there.
I've been looking for you.
Yes.
I hope you were part of my presentation. Ladies and
I
gentlemen,
saw it.
Professor Agwanda Alfred is a holder of Bachelor of Education Science, a Master of Science in Population Studies, and a PhD in Population Studies and an MBS. Professor Agwanda has taught for 37 years at various levels of formal education. He has taught at the University of Nairobi, Population Studies and Research Institute for the last 28 years. He is currently an Associate Research Professor at the Population Studies and Research Institute, University of Nairobi. In 2019, he was awarded MBS in recognition of his role in carrying out the population and housing census in Kenya. It's my honor and privilege to welcome you, Professor Agwanda. I hope the center will share your screens, or if not, you can also share your screens.
Let them share my screen.
James Masharia, could you please share the presentation for the professor? James Masharia, are you there? Thank you. Karibu, Prof.
Okay. I think some of the first two slides have been mentioned by our chair. I think go to slide 3. Slide 4. We'll go to slide 4. Okay. I think you have mentioned that this is something that we have not been focusing on. 3 in every 1,000 girls aged 10 to 14 have children. And this has not changed for the last 30 years. Data has been available from DHS and even some censuses, but we have chosen to ignore this. We measure fertility from 15 to 19, but we have ignored this group. This is my message. And if you look at the rebirth rate for this group, you find that there are about 6,000 births that occur among this group every year. Now, I have the privilege to have even seen the DHS data, the census data 2019, this has not changed. And this is where we need to focus on. There's been little data and little programs that focus on. And that is the message I want the people to see beyond what the chairman has reported. Next. Now, this has been shown, but I'm trying to say there's one important element that we have not focused on. Yes, there are, I think now 2015 malaria indicator survey indicates 96 births per 1,000 women. The DHS, the census is likely to have it's about between 50 to 55 per 1,000, but we have not focused. No, we will just go back. but we have not focused on one thing. Those adolescents that have children, more than one child before the age of 20. We have not focused on this. The DHS data is there, but we have not had, this group needs a little bit of special programs and not to be lumped with the others. Finally, I want to, next slide. Yes, the adolescent birth rate is not the same everywhere. 23 out of our 47 counties have birth rates above 100 per 1,000, which is very, very high. The highest rates are in Narok, Homa Bay, Samburu, Tana River, Migori, Turkana, and West Pokot. There's one thing that you can infer from this group, following what the chair has said. Where adolescent birth rate is high, poverty is also high. And I want to mention one thing. If we have not, and we have not had studies that examine the cases of repeat pregnancies during adolescent period. And we need to focus and give a special consideration for this group. About 95 for every 1,000 women have a second and a third birth rates before the age of 20. And this one has a lot of implications on their human development, access to education, access to healthcare, employment, and even participation in the labor force, because child rearing is not an easy task. It takes time, and therefore they spend more of their time looking after children than contributing also to the welfare of the entire family. What was there in the presentation in the plenary by Elia, those who are not in school, those who are not in employment, those who are not doing anything, there are 13 million, and part of that contribution comes from this group. Well, my question is, between now and 2025, there'll be about 7.2 million births. 13% of these 7.2 million will occur among adolescents if everything remains the same. How is the country prepared for these high-risk births? The chair has mentioned the problems. The next, I end my presentation here. Two things that are important. Repeat adolescent pregnancy among early adolescents below age 15, and that we are likely to have 7.2 million births. 13% of them will occur among this group if things do not change. That is my message. Thank you.
Wow, what a hitting statistics. Thank you very much, Professor Akwanda. First of all, for giving us the hitting statistics on the implications of this agenda on the future population and development of this country. Secondly, thank you very much for keeping time. As we discussed, we have kept time, and I think we may have even used less than your allocated time, and we can help utilize this time with other panelists who had longer presentation. Thank you very much. We will allow all the panelists to do their presentations. Please put their questions. I can see some chat questions. Put your questions in the chat for us to respond to at the end of the session, and then we'll also have an interactive session at the end of the panelist presentation. Allow me, therefore, to welcome Professor Ruth Nduati, who is an epidemiologist, a holder of MBCHD, ML in Pediatrics, and NPH in Epidemiology, Professor of Pediatrics and Child Health, University of Nairobi, and a consultant pediatrician at Kenyatta National Hospital. She is the chairperson, governing council at the Kiriri Women's University of Science and Technology, and a HIV researcher in the field of mother-to-child transmission of HIV, and published extensively, contributing to knowledge, health policy, and current practice guidelines in the field. Professor Nduati serves on different technical committees that support the work of the Ministry of Health, especially in the field of HIV, breastfeeding, and more recently in the COVID-19 response. She is a member of the team that conceptualized the Community Child Health Kenya, a program that brings together residents from the University of Nairobi and University of Washington to study child health together in the rural Kenya. Current sites are Kisii and Naivasha for that. She is a co-PI with Professor Dalton Wamalwa for an NHI Fogarty grant, which is called HEPI Kenya, that seeks to strengthen interprofessional medical education and research linked to prevention and healthcare provisions at 4 public universities and related teaching hospitals. Professor Duarte has received several awards in the recognition of our professional achievements, among them inclusion in the Kenya government publication, Pioneers and Transformers, The Journeys of Women Trailblazers in Kenya, Kenya Yearbook Editorial Board Biography Series. Professor, it is our honor and privilege to have you on this. Please welcome and do your presentations on this important agenda.
Thank you very much, Dr. Bashir, for the very warm introduction. And I feel very honored to have been asked to speak in this panel. I must also acknowledge that your presentation covered some of the ground I was going to present, but nevertheless, I will go on and present. Next slide. I was asked to talk about adolescent development. Next slide, please. And my first slide was to even just ask, what is human capital and what do we understand about it? And the term human capital is really economics jargon for the rest of us, but in simple terms refers to the habits, knowledge, social and personal attributes, including creativity embodied in the ability to produce labor, to perform labor, to produce economic value for an individual, the employer, and their community. Now, a critical building block towards your intellect, which is intelligence, and using one's mind creatively. Intelligence, or IQ, as we doctors commonly know it, is commonly referred to as key to human and economic success. And as I was doing some reading around this topic, one of the statements that stands out is that a 1-point increase in the national average IQ is associated with a persistent 0.11% annual increase in GDP per capita. So truly focusing on human capital development is critical to our nation's development. Next slide. Now, the human brain's ultimate structure and capacity is shaped early before the age of 3 years. In fact, when we talk about IQ, we're really talking about the brain. The dimensions of growth are cognition, social and emotional, and failure to optimize development in early life has really long-term consequences in terms of education, how you perform it when you're exposed to education, or your job potential, or even your adult mental health. I see that the slides are frozen. I hope that's not for everybody. I can see the correct slides on my side. Now, teen pregnancy or teen motherhood creates significant vulnerability. It is harmful to both the young woman and her baby. And in fact, it robs Kenya of its human potential. Breastfeeding and nurturing care for the young infant contributes to one's bonding to their mother. And it's a critical step in development of your IQ and your human capital potential. So some of the solutions we have for our teen mothers going back to school breaks the bond between the mother and the child and increases the vulnerability of this baby of a teenager and an increasing risk of early death or exposure to what we call adverse childhood events, which we know are associated with bad outcomes in adulthood. Next slide. Now, the human brain grows, all the way from in utero and all the way into adulthood. This picture is just to show you that when we talk about the brain growing, that there are physical changes taking place. The more red, the younger the brain, and as it matures more, it's much more blue. And the period of early infancy and also the period of adolescence are particularly important periods in the development of the brain. Next slide. The next slide, please. This next slide focuses on the first 1,000 days of life. That is conception to 3 years. 90% of a child's brain is developed at this point. In fact, 90% of our brains are developed by the time we achieve the age of 5 years. The slide also shows that there are different components of the brain, and they all have different growth trajectories. So problems that occur like malnutrition or emotional neglect have very serious threats to the development of the brain, and those threats persist beyond childhood. In fact, what is most well appreciated is the effect of chronic malnutrition, stunting. That individuals who their stunting is not corrected by 3 years, by the time they go to the school, they're in class in standard 6, or they are finishing school at age 18, their performance is at a lower level than their age mates growing in the same environment. Now, what's emerging from research in the developed world is the issue of neglect. And I was not able to show the pictures, but pictures of the brains of babies who have been neglected. They are shrunken. There's less white matter. There's less gray matter. Clearly, a very adverse effect. In our country, we are not capturing enough data about how many children are really in circumstances where they're neglected, and so losing their human capital even before they get to the classroom. Now, when you have these effects on the brain, they have then the long-term contribution to school failure and the vicious cycle that has been described. Next slide. Now, once we reach adolescence, they have a critical developmental challenge, things that they have to go through. And this includes physical growth, it includes sexual maturation, it is emotional development and cognitive development. In fact, in the age group between 10 years and 19 years, there's a doubling of one's weight and gaining of about 20 to 30% of their adult height. To do that, you need adequate nutrition. So adolescence becomes another period of vulnerability towards malnutrition. Now, the more important is the issue of this cognitive development. The cognitive development comes later than the physical development, and in between there are the issues of emotional development, the importance of peers, and even challenges in navigating the space between the adolescent and the family. The tendency in our society is that once somebody looks physically mature, they have gotten their sexual characteristics, is to assume that they are an adult. And the result is that there's a lot of conflict between parents of adolescents and adolescents, because parents think they are dealing with an adult, but and yet the adolescent is a young person. Next slide. Now, the brain of an adolescent, I think we can say it's a brain under construction. But all is not lost in terms of the adolescent at this stage. They have a great capacity to learn and create. There's a huge potential for the education sector or the sector that training skills to train people and to have them perform and drive our economy. Now, at the same time, they have increased, the brain is, because the brain is growing, there are a lot of metabolic changes going on. They have increased risk of damage from drugs and alcohol. They have increased likelihood of being addicted when they're exposed to these drugs. There's also an increased risk of mental illness, and there's also this drive to actually take risks. there's also the point that the parts of the brain that contain the emotions are not mature. So you all know teenagers, sometimes they have outbursts, they get angry, they're emotional. This is part of the normal development process. Next slide. The part of the brain that deals with executive functions, that's including weighing long-term consequences, controlling impulses, being able to see that my action today has an impact on tomorrow, is the last to develop. And the data that's coming out now is that this doesn't take place until you're into your early 20s. So really, the whole period of 10 to 19 years, you're actually dealing with children and who their decision making is not like that of an adult. They don't fully appreciate that, you know what, even I'm not going to use a condom today, I like you, that decision may have very major ramifications for on their life, for the rest of their life, actually. Next slide. So so to quickly summarize the development is that early adolescence, you have physical and sexual development. There are also sexual desires and urge to experiment. Mid-adolescence, the adolescents feel they're invincible. And so at this point, they engage in risk-taking. And risk-taking is typical of adolescents all over the world. It's usually forming gangs, which we know we haven't talked about, but the boys are engaging in gangs, in violence. It's taking drugs, and it's also engaging in initiating sexual activity, which then comes with its package of STIs, HIV, etc. And it's only in late adolescence that now their cognitive function is mature and they start engaging in long-term relationships. A very, I think, sobering thought is that in mid-adolescence, you have these serial monogamous relationships, and this has been documented in adolescent research in our country. So yes, I'm faithful, but I'm faithful this month to A, and I'm faithful to B in the next month. And an issue that needs to be taken into account as we cancel adolescence. Next slide. Now, when we have early sexual debut, then these are the consequences. I will not belabor them. This is a slide that was based on an analysis done by a community as part of those child health studies we do in rural Kenya. And you can see some of the issues that come up is the issue of preterm births because of induced abortion as a strategy of getting rid of the pregnancy. Infanticide, which is not often discussed, but is an issue and has been documented. And then, of course, the stigma, the risk of mortality for these kids, and the poverty that is generated. Next slide. Now, WHO has been on the forefront of programming for adolescents, and a report going back to 1997 highlighted the importance of parents. Particularly 5 roles were identified for parents. 1, the issue of loving your teenager, loving your child. 2, setting limits. 3, being respectful of that child and their individuality. 4, modeling behavior. And 5, providing protection. I'll just show some information on 3 of them. Next slide. A child, an adolescent, so the first step in loving your child is to breastfeed. In breastfeeding, it's important in that not only does it provide food, but the process of breastfeeding allows for bonding between the child and the mother. And throughout life, as a child, as a baby, as a child, as a teenager, the strength of bonding between that child and the parent is probably the most important behavioral moderating factor that exists. So if we have good bonding early, such children are less likely to engage in high-risk behavior. Now, the second thing is that breastfeeding increases the IQ. I quote data from developed nations. You know, usually we present data from developing countries and where there are many other problems. But this is data, particularly the study from Belarus, one of the Russian states, where they had a study where they were randomized communities to promote breastfeeding. And what they found is that babies who were breastfed, in fact, the average duration of breastfeeding was a year, but babies who were breastfed for 6 months were compared to those who had been breastfed for 1 month. And at age 4 years, the baby who had been breastfed for 6 months had 6 IQ points higher than those breastfed for 1 month only. I challenge us, and this is something we can do. This is something we can deliver to Kenya. Increased IQ of the general population. Next slide. Next slide. So how does loving your child, how does that loving your child connect to the adolescent behavior? If you look to the right, adolescents who feel connected to their parents are less likely to consider suicide or be involved in interpersonal violence. They're less likely to start using drugs, and they are more likely to defer sexual activity. Next slide. Parents who set regulations and monitor their children. So you're taking the position that my child is a child and I'm going to monitor them. You supervise, you establish behavioral rules, and you convey clear expectations. Such children have decreased risk of drug and alcohol use. They have decreased sexual activity. There's later age of pregnancy. There's reduced likelihood of depression. They have decreased school problems. They are less likely to be victimized or delinquent, and they have decreased negative peer influences. And I want to urge particular parents living in urban areas, every corner away from your house, there's somebody who's peddling drugs. Making sure that you know where your child is. Don't be told that I'm at the neighbors. Finding out and actually being accountable for making your child accountable for their time. Adolescence. Next slide. Next slide, please. Next slide. And this is the slide around the issue of respect and individuality. Please, yes, you've skipped one slide. The respect and individuality. The respecting the child also, it's okay, go to the next slide. Reduces the risk of depression. It reduces the risk of mental health problems. And then this is my second last slide, almost last slide, where provision and protection is important. We have very good policies about trying to transit children from primary school to secondary school, but we are also undermining that process. For example, we send children home to go and collect school fees, and in the process of collecting that school fees, the children are harmed. When you send a child away to collect school fees, first of all, there's the loss of face, you diminish their esteem. Where they are going to collect school fees on the way, they may meet people who harm them. It also increases their likelihood for wanting to engage in transactional sex as a way of getting their school fees. So if you remember, when we received results of Form 4 recently, 2 headmistresses, one from Moi Girls in Eldoret and Kenya High, their big strategy was they kept the girls in school, the adults and the teachers figured out where school fees will come from for those children. Next slide, and this is my last slide. It's just to emphasize that that developing our human capital is linked to issues of development, and it is a life, it starts all the way from pregnancy all the way to adulthood. So we need to develop it, we need to protect the family, we need to ensure school is done well, and then we refine it by providing the skills out there. And as we're doing that, we need to find safe spaces for children to play. Play is what delivers creativity. You remember we talked of creativity at the beginning. Creativity is developed when children are allowed to play and explore their environment. Thank you very much. I'm sorry I've taken maybe longer than I should, but I thank you again for listening to me.
Thank you, Professor, for that elaborate, very informative. I'm sure it's an eye-opener for many of the audiences around here. That science is hardly shared in such fora, and we appreciate your contribution on this. Asante sana, and therefore, I don't know how we are dealing with time, but I want to welcome our next presenter, who is Pamela Onduso. Pamela Onduso has over 20 years of progressive experience in sub-Saharan Africa working with private and public sectors on population and sustainable development, adolescent and youth sexual reproductive health and family planning, program design, management, advocacy, and policy. She has implemented USAID-funded global youth programs, including expanding service delivery, evidence to action, and focus on young adults. She supported the Africa Youth Alliance, the first youth program funded by Bill and Melinda Gates Foundation in Uganda, Tanzania, Bosnia, and Ghana. In Kenya, she supports USAID Afya Pwani program using media, film, radio, and documentaries for advocacy. Pamela, welcome, and the floor is yours. Thank you.
Good afternoon, distinguished guests, ladies and gentlemen, young people and the young at heart, fellow panelists, all other protocols being observed. Welcome to this presentation where we will be looking at measures for curbing adolescent fertility. Next slide. A word about the organization I work for. We go where the need is greatest globally, enabling communities to make voluntary and informed decisions about their health and futures. We've worked in over 60 countries, including Kenya, since 1957. And adolescent, youth, and sexual and reproductive health is a key impact area of Pathfinder's global strategic framework. Next slide. As demonstrated by the very long list on this slide, Kenya has a strong policy environment in support of AYSRH, and we are indebted to the government of Kenya for this support. The challenge for governments, including Kenya, and stakeholders is moving from policy commitments to implementation. The extent to which policies are implemented is the true measure of improvements in youth health and well-being. Next slide. This slide looks at several things. The first is that adolescents are heterogeneous, and this has been said by every speaker. Therefore, the developmental goals have to vary depending on the age, as indicated in the table, to address the drivers of poor health outcomes, which are indicated at the bottom. And when we look at very young adolescents who are beginning to engage in some sexual activity, and if we were listening carefully to Prof. Agwanda, this 10 to 14-year group has been typically overlooked, and that 3 in every 1,000 girls has been giving birth for over 30 years. It's important then that we recognize that the developmental goal there is delayed sexual debut and harm reduction. And therefore you see a series of activities, the knowledge, attitude, skills, and behaviors, including body awareness, the menstrual hygiene, education and management, communication and interpersonal skill building with parents, those linkages with family and community, the support systems, early pregnancy prevention, because we know they're at risk, high risk of getting pregnant, HIV and STI prevention, equitable gender attitudes, and also discussing issues around female genital cutting. Early marriage prevention, primarily doing that with communities because the drivers are usually the older adults in the community. Protection from sexual violence and unwanted sexual activity, and then ensuring the provision for those in need of quality SRHR services. When we look at the older adolescents, this is where you've got the increased risk-taking. And this is where we heard from, I believe, Prof. Agwanda, that 11% of Kenyan adolescents and youth in this age group proceed to have children before the age of 20. And that the repeat pregnancies here are on the rise. And therefore, this is a group we need to look at very critically. So again, we're looking at delayed sexual debut, but we're also looking at the use of family planning at debut and contraception. So again, we're looking at the knowledge, attitudes, skills, and behaviors, keep helping girls return to school, and also to prepare for the workforce or further study. We heard discussion around technical and vocational education and opportunities like that we need to push. Early pregnancy prevention, STI prevention, equitable gender attitudes, behaviors, and norms. So we're bringing in their partners, early marriage prevention, where possible, so that we can keep them in school, access to services, and the voluntary use of family planning methods at the time of sexual debut and beyond. And then we look at the 20 to 24 and older, the emerging adults, who include first-time parents, who are a group I don't think we have looked at in Kenya as critically as we should. So here we're looking in terms of the developmental goal at spacing pregnancies and fostering leadership, all of the SRH knowledge, attitude, skills, and behaviors, coupled communication skills for establishing and achieving their personal and family goals. Extremely important. And then facilitating workforce participation, because once baby comes into the picture, you definitely will need resources to continue to raise this child. Access to and use of quality antenatal care, maternal and infant health services, including feeding, which Prof. Nduati has so eloquently explained, breastfeeding and infant care practices, healthy timing and healthy timing and spacing of pregnancies, postpartum family planning so that we don't have repeat unplanned, equitable gender attitudes, behaviors and norms, HIV and STI prevention. And then, because we're talking about human capital, helping this generation become leaders and advocates for better policies for young people, so that we're not having to deal with all of those drivers that appear at the bottom of that, the school dropout, the early marriage, the unintended pregnancies, the girls and women's lack of agency, the gender-based violence. Next slide. So WHO lists several interventions: CSE, youth-friendly services, community and family support, the girls' empowerment. And I think an emerging and enabling one is digital technologies. And they have an excellent publication on youth-centered digital health interventions, a framework for planning, developing, and implementing solutions with and for young people, that was published in Geneva in 2020. Next slide. In terms of comprehensive sexuality education, repeated studies over the last 3 decades have demonstrated the utility and importance of age-appropriate comprehensive sexuality education across a range of topics and classes. And CSE topics typically include reproductive health, body changes, friends, culture, human rights, pregnancy, STIs and HIV, self-esteem, future aspirations, GBV, etc. This has been a complicated discussion in our country, but it's a necessary discussion in light of the information that we're receiving, that we are having young people, and have had for over 30 years, who have been giving birth while still in school and as young as the age 10 to 14. Next slide. This is an example of youth-friendly services, a program that was run in Bungoma County. It's called the After Hours Adolescent Project, which was a randomized controlled trial that increased adolescent SRH client visits by 87% in just 1 year in intervention facilities, relying entirely on government health facilities, providing no incentives. The project's trainers and implementers were all Kenyan nurses and comprehensive sexuality education specialists with minimal outside support. I cite this because in 2020, the Adolescent After Hours Project received a W Health Organization Implementing Best Practices in Family Planning Award for high impact family planning. And what they did, which was very interesting, very simple, very basic, an MOU with the Ministry of Health in the county before the project launch. They then hired and trained 10 newly graduated young nurses and trained them in youth-friendly service delivery and CSE. And then the nurses worked part-time on CSE in the schools, but also went out to the communities. They then hired what they called CSE rovers, secondary school graduates, who assisted the nurses to extend CSE and make it known in the communities, young people. The health facilities that took part in it then extended the clinic hours to evening, 6 p.m. on weekdays, and included and offered to provide services one day of the week. And then they guaranteed buffer stock, so contraceptives, condoms, diagnostic tests, and then they undertook facility upgrades. So improved the lighting, made sure there was a room for the youth to sit in, desks, and so forth. Next slide. The GREAT project is an example of community and family support. And GREAT stands for Gender Roles, Equality and Transformation Project. And it aimed to promote gender equitable attitudes and behaviors among adolescents ages 10 to 19 and their communities, with the goal of reducing GBV and improving SRH outcomes in post-conflict communities in northern Uganda. And they implemented a set of participatory activities that engage the adolescents, but also the adults in discussion and reflection. And the activities included a radio drama. It included an orientation for the village health teams to help them offer adolescent-friendly services, and a toolkit of reflective activities for community groups and school-based clubs. And the evaluation revealed that it actually led to improvements in gender equitable attitudes and behaviors among exposed individuals. Next slide. Next slide. Another girls' empowerment programmatic example is DREAMS, or Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe, which is a public working with USAID in 15 African countries. And it targeted girls and young women 9 to 24. It began in 2015 and it's running to date. And its success is because it's organized around 4 categories. The first is services that directly empower the adolescent girls and young women, and those are shown on the slide. The next is services that mobilize communities to support and protect the adolescent girls and young women. The third is services that strengthen adolescent girls and their families. And then finally, services that decrease risk among the male sex partners of adolescent girls and young women. Next slide. A couple of recommendations. Education, education, education. Delaying age at marriage. The need for increased youth access to sexual and reproductive health information and services, that has been all said by previous speakers. Raising youth voices. We have a young person on this panel, Nyokabi. I hope she'll talk a bit about that, youth engagement and partnership. Age-appropriate sexuality education. And also critically promoting technical and vocational education and training, because job creation is critical with so many young people who are out of school, scaling up vocational training centers, which is what was said by a government official earlier in the morning. Empowering parents. We heard from Prof. Duarte about the important role that parents and communities play in terms of love, protection, support, and helping young people set limits. The whole area of allocating resources for AYSRH, what gets budgeted gets done. Adopting multi-sectoral holistic approaches where we're working and encouraging the private sector to support the public sector. The use of technology, but wisely and creatively. So WhatsApp learning, e-learning, digital platforms, social media, and gender synchronizing SRH interventions, engaging both the male and the female partners for positive outcomes, improves use of contraception and other needs. And then I mentioned earlier, young couples interventions. We need to explore her, his, and their family desires, fertility desires, and contraceptive behaviors, and plan for program scale up. Let's move away from pilots Let's think about sustainability. Let's anchor our programs in existing structures. Let's anchor them with our host country governments and ministries of health. Thank you.
Thank you, Pamela. Thank you very much for that insightful presentation. I'm not sure whether we're doing very well in time, so we have still Dr. Kihara and two adolescents to share their experiences and still provide space for interactive panel discussion. So may I take this opportunity, therefore, to welcome Dr. Ann Kihara. Dr. Ann Kihara holds a fellowship in obstetrics and gynecology from the Issak, Eastern Central Africa, Southern African College of Obstetrics and Gynecology, an MSF from Luxembourg, an International Union Against Tuberculosis and Lyme Fellowship in Research, Operation Research, College of Health Sciences, Manitoba, Canada, Certification Research Capacity in MNCH, University of Nairobi, Kenya. She has done her MMed Obstetrics and Gynecology, and University of Nairobi, Kenya, her MD-CHB Medicine and Surgery. Her brief working experience include, she's a consultant in obstetrics and gynecology and senior lecturer at University of Nairobi, Department of Obstetrics and Gynecology, Kenya. She's an ardent advocate for women's health with special interest in adolescent and youth sexual reproductive health and rights, have over 90 peer-reviewed publications and contributed to evidence-informed clinical practice guidelines, policy, and advocacy locally and internationally. She is the current president of the African Federation of Obstetricians and Gynecologists, AFOG, and the past president of the Kenya Obstetrical and Gynecological Society. Dr. Ann, the floor is yours. Welcome. It's our pleasure to have you here today.
Thank you very much, Dr. Bashir, and to the audience and to my fellow presenters. You're most welcome. I'm taking a slight tangential shift. I want us to look at social accountability. Next slide. I have a brief outline of this presentation, just give you a background. Why is social accountability important? And factors that influence, and how can we measure? So this is what I will be speaking about. Thank you. Next. Next, please. So a brief background. Really, the focus on the adolescent came up when we had the global strategy, where they stopped just looking at the woman and the child, but have extended that to include the adolescent. And amongst their direction and the strategy is the last stanza. It's intended to guide and enable people and communities to drive change, claim their rights, and hold leaders to account. Further documents have actually looked at accountability. We're talking about the demographic dividends, ICPD plus 25, universal health coverage, the Declaration of Astana on primary health care, our sustainable development goals, where we are clearly saying, leave no one behind. And within the Kenyan context, our constitution, Vision 2030, the Big Four agenda, our strategic plans, which Pamela has really alluded to, the policy and strategic environment that exists. But I must dare say, we must begin to think about the investment frameworks, particularly addressing this group. And how do we account? Regular monitoring and accountability are vital, not only to assess progress and to assure that all people at all ages are getting quality care they need for their health and well-being, but also that duty bearers and public sector are accountable. So we have the Global Strategic Accountability Framework that clearly states we must be regularly monitoring, we must be reviewing, we must be acting. So it's not good enough to be talking about data of 2014, 2019, we're in 2021. That already tells you we have serious gaps. Next, please. So I will not belabor to this slide because we've all talked about the reproductive and maternal issues that are also affecting and afflicting our adolescents. But I want you to focus on the last 3 points. We need to emphasize on education. We need to emphasize even more on nutrition, which Professor Duarte has alluded to. And we also need to really think through social livelihoods. I have put a little box which is reflecting what happened to us last year, just between January and May. In Nairobi County, we had 11,195 teenage pregnancies. Are we really being accountable to this age group? Next, please. So, what we want to look at when we think of social accountability, really there are 2 main things. Are they getting their needs, and are we being responsive, particularly those who are more vulnerable and marginalized? Who am I thinking about? The very young adolescent, the 10 to 14, the girl in the rural village, the girl in the urban informal segment, the girl who's probably incarcerated, persons with disability, the list goes on and on. But are they able to get health care? Then the second one now speaks now to the state actors being accountable to communities, and particularly in this case, the adolescent. So what are we asking the community, who is you and me? How do you contribute into the political and social empowerment? Are we inclusive in utilization of public services and eradication of harmful practices? Policies and practices to tackle poverty, to have everybody socially included and not excluded or marginalized? And are we having programs, like Pamela has begun to allude to, actually address this? And are goods and services available, acceptable, affordable, accessible, and sustainably so? And are they of quality for the adolescent? And are we correcting for waste and mismanagement? And what do we expect the impact would therefore be? We would have the marginalized, vulnerable, and at-risk adolescent acquire 1, dignity, 2, be empowered, 3, to be included, and I dare say not just for human capital, but we will have gained as a nation in social capital. So it's not just their health, it's not just the development agenda, but even the trust and relationships that go and cut across all ages. Next, please. So I want to belabor what I feel should really be informing getting the needs and being responsive to adolescents. And I'll start with the top, leadership and coordinated mechanisms. It will never work if we do not engage them. It must be the center of our focus. 10 to 14, Professor Gwanda clearly says neglected. By the time you're hitting 19 and above, it's too late. Too much has happened. Too many first-time pregnancies, too young. Too many repeat pregnancies, too young. The other thing is policies and strategies. We have them in place, but are we making them as living documents? Therefore, organically evolving with the need. The data clearly shows us different counties at different page sets, and all adolescents are not homogeneous. So are we making them applicable in the context of even the counties you work from? And are they being implemented and reviewed regularly? And this therefore requires what? Constant look at strategic planning at multi-level, multi-stakeholders, multi-sector. And that's the only way we're going to have social behavioral change and sustained community engagement. Universal health coverage and primary health care, prioritizing. Are we having our young youth or young adolescents as part of that equation? Are we empowering them even to access services? So are we having financial programs that speak to how they can get care? And what is their minimum package that they can therefore access? Then how are we empowering communities? And are we also thinking of environmental sustainability as a social responsibility? running concurrently. Next, please. Communication strategies, I will not belabor beyond, but we know all these youngsters are very IT swervy. So when we look at communication strategy, it's actually putting ourselves where they are. They're far ahead of us. I keep saying I'm a born before computer age, which is not the same for that young adolescent who's gotten exposures from when they were a very young child. And therefore, it brings a second point. We must embrace technology, but put in evidence-based knowledge products, share information, provide service linkages, and also use it for data capture. The third thing is providing safe spaces. And as Prof. Duarte clearly said, it starts from their young childhood development, safe spaces to play. But what do? Let's look at the Nairobi urbanite life. Parents will take their children into areas that you would actually say are questionable. So you find the child is in a bouncing castle, the parents are having a drink on the side, and at age 10, 11, 12, you start telling them, do not take alcohol, do not drink, do not be in this environment. But what have you exposed them to when they were in their formative age? Safe spaces, safeguarding. Are you exposing these young girls into vulnerabilities? Schools were shut down last year. We have had a plague of pregnancies countrywide documented. So what are we doing as far as safeguarding is concerned as a nation and as a people? Elimination of harmful practices, but what fits in their place? Because this is tradition. How do you break that yoke? Giving alternative rites of passage, healthy recreation, promoting health promotion and primary prevention strategies should be really at the forefront, and giving art, music, culture, sports, hobbies to these youngsters so they're productively engaged and not having the devil's workshop because of idleness or being misdirected. Next, please.
Dr. Kihara, I will push you. Sorry, you are the last presenter.
No problem. I'm almost there. Okay, next, please. Next, please. Next. Next slide, please. Good. Sorry, go back. So I want to look at the state actors, and what they are really responsible for accountability is in public policy, budgeting and expenditure, public service delivery. Those are the three arms that we really need to look at, and we need to become the advocates through a coordinated mechanism. Next, please. Next. Factors influencing accountability. I will only read the top. Go back, please. Harnessing the local context, decentralized health system, and looking at equity issues, strategic accountability, as opposed to tactile. A lot of our civil societies really have a voice, but it's not orchestrated as one. So can we come together? Multi-stakeholder and multi-sector approaches. Next. I won't belabor to it. Acknowledge the patient rights approach. This is important. Age and gender disaggregation of data. We have to break it down. Not just what is your age, what is your gender, what is your geolocality. Scaling up of coverage and utilization, and formation of partnerships, not just within the public system, but public-private, and also north-south and south-south, as was spoken of this morning. Next, please. Power relations, and I want to just belabor this as my main issue of focus. When we talk about politics, religion, culture, family, it is really the breach in power relations. So we really need to start beginning to even do studies that look at the relationships of how these interact together with the adolescent. The media, which we haven't mentioned, again, another area we need to look at, and evidence sharing as we are doing so today. My final slide. Next. So I've just shown you how we can measure. It should be both quantitative, measurements where we're looking at scorecards and also auditing, and also looking at power relationships, which is more of a social science where you're actually looking at qualitative evaluation. Are we making any gains? My last statement on the last slide, I think, is extremely important. I mentioned, next please, we must provide social accountability and accelerated action towards gender equality in this generation so that the promise of SDGs can be actualized. And that means what? Really understanding the scale of the challenge for Kenya. Thank you very much.
Thank you, Dr. Kihara. Thank you very much for that presentation. We are at 2 p.m. and we have 2 adolescents whom we will give each 3 minutes to share their experiences. My honor to welcome Ms. Hope Nyokabi. She's currently pursuing Bachelor of Laws at the University of Nairobi. She attended the Kenya High School between 2014 and 2017. She's a charismatic advocate of the rights of children, girls, and youth. 21-year-old Hope was raised by her mother in Kawangware. Her achievements are she served in the Kenya Children's Assembly 2011-2015, member Kenya Alliance for the Advancement of Children's Rights 2011. She represented Kenya at the UN Convention on Rights of Children 2014 commemoration in Rwanda and Commission on the Status of Women in New York in 2015. A bright student, Hope assisted her mother to finance her education through hard work earning. Equity Wings to Fly 2014